My name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. And today's event is entitled Therapy Staff Turnover in Skilled Nursing Facilities, Facility Characteristics and Associations with Resident Outcomes. And for those of you who aren't familiar with HWTech, we're based at the Center for Health Workforce Studies, the one in New York, not the University of Washington one. There's a few of us, as I guess some of you may know. And our primary mission is to provide technical assistance to states and organizations that engage in health workforce planning. And for those of you who have not already, by all means, check out our website at healthworkforceta.org. We have extensive resource library of videos, webinars, reports, etc. And by all means, sign up to our email list so you'll get notifications of events like this. Now, let me introduce you to today's speaker, Rachel Prusynski. She's from the Department of Rehabilitation Medicine at the University of Washington School of Medicine, and she's also affiliated with that other Center for Health Workforce Studies located on the other coast at the University of Washington. Rachel, welcome.
Thank you, David. So yeah, thanks for having us and thanks for having me and for those who are joining. And I know we'll send the recording out to other folks as well. So I'm Rachel Prusynski, as David said. I'm full disclosure, I'm a rehab clinician, a physical therapist by training, which may be where some of my bias comes from in terms of wanting to study the therapy workforce and thinking it's just as important as nursing in some regards. So this project is from a study from the other Center for Health Workforce Studies, or CHOOSE as we call it, that's funded by HRSA, and just saying no conflicts of interest. On behalf of myself and my co-authors, Tracy Mrose and Bianca Frogner from UW CHOOSE. So before we kind of talk about the therapy work first, I just want to sort of level set and really just talk about what setting we're discussing today. So the skilled nursing facility, or SNF workforce, I like to introduce the fact that there are a lot of confusing terms here. So SNF and nursing home are actually often used interchangeably, and that just really describes the physical setting or the building that people work in and patients are seen in. But there's two really distinct patient populations that have two different clinical needs and different payers that are often served by the same workforce. And so while there's, over almost 15,000 of these buildings, these unique SNFs in the US, they serve short stay post-acute patients who are there for, a brief period of time. They've had a hospitalization and are receiving rehab services and nursing to sort of recover. And those folks are served by the same workforce as long stay nursing home residents who live in the building full time. Their care is covered by Medicaid typically, but they can also receive rehab services that will be paid by Medicare Part B. So I think that's an important distinction to think about as we talk about some of these outcomes and turnover in this study. But in general, in the entire nursing home workforce, so that includes health workers, but food and safety, janitorial staff, just everybody. There's over 1.3 million total employees in SNFs across the US. And for healthcare staff, nursing obviously makes up the largest component of that. So there's about 750,000 registered nurses, LPNs, and nursing assistants working in US nursing homes, or SNFs. But despite the much smaller size of only about 45,000 employees, therapy makes up the second largest chunk of healthcare staff in nursing homes. And the 5 specific job roles that make up the therapy workforce are physical therapists, or PTs, their assistants, occupational therapists, or OTs, and OT assistants, and then speech language pathologists, or SLPs. Okay. And kind of going back to the reason for this study, really nursing turnover in SNFs has received pretty substantial attention, both by policymakers and in the literature. And that's because, the idea is that high turnover of staff leads to low continuity of care and poor outcomes. And I think that's especially pertinent in the nursing home population or in SNFs because there's a lot of medically and clinically complex folks. There's a lot of patients with dementia who really benefit from and require really more familiarity and continuity of their caregiver staff. The estimates of nurse turnover are very wide-ranging. That depends a lot on, the time period that it's measured for, different specifications, but from 30 to 140% of nursing staff in US SNFs turns over every year, depending on which staff are being included and who's doing the measuring. And while that's a pretty wide range, very consistently high turnover of nursing occupations has been associated with negative patient outcomes across, a broad number of studies. And for that reason, nurse turnover measures are included in multiple sort of quality reporting programs by CMS, the Centers for Medicare and Medicaid Services. So nurse turnover is measured at the facility level for all SNFs, and those ratings are included as part of the five-star quality rating system. So we have this understanding sort of that nurse turnover in SNFs is negative for patient outcomes. And we need to be measuring it and we need to be preventing it, but we really don't have that same sort of understanding for therapy staff. And there are two sort of main reasons why we think folks should care about therapy turnover. And so just from a quality reporting standpoint, CMS cares about and measures aspects of clinical outcomes and quality for patients in SNFs that are things like mobility, safety, falls, functional independence, and those aspects of care are addressed by therapy staff, but we really don't have any idea about how stability in the therapy workforce might impact those measures. And that second reason is that the therapy workforce in SNFs has been uniquely impacted in recent years by large CMS policy shifts that really changed the incentives for those post-acute skilled nursing facility stays, so those short stay patients. And that actually led to really substantial declines in both the therapy workforce, so the number of therapists and assistants that are actually staffed or working in the nursing homes, and to therapy provision. So this chart is from a study we published last year. Over time, you see that this is actually the amount of therapy patients during their post-acute stays were receiving, and there's a really substantial decline, especially for physical and occupational therapy, when Medicare passed the patient-driven payment model, which removed the financial incentives for skilled nursing facilities to provide high-volume rehab care. And then we did not see that sort of service provision rebound, even as the pandemic sort of wore on. So we're still providing a lot less care to patients in skilled nursing facilities. So despite sort of these recent declines and the importance of rehab services to quality of care, really, we don't know a lot about therapy turnover. We haven't characterized therapy turnover or tried to link it to patient outcomes. So that's what we tried to do in this study. So we had three sort of broader objectives. There's a lot of analyses, and so I'm going to try to really stick to kind of the main ones. But we wanted to first just describe trends in therapy staff turnover in SNFs. Then we have two sort of exploratory analyses. So again, this is kind of descriptive exploratory work. And we identified skilled nursing facility characteristics that were associated with high therapy staff turnover, and then estimated relationships, if any, between turnover and specific rehab relevant outcomes for both short stay patients and then long-term care residents in SNFs. So I'll start with just sort of our descriptive component. So we used public data from CMS called the PBJ, or payroll-based journal, and CMS provides daily staff hours for every employee in every skilled nursing facility across the US for the most part. And we looked at data between July 2020 and September 2023 for all of these analyses. There are some more recent data on staffing, but we couldn't, there weren't more recent data on outcomes. So that's where we had to sort of stop our study. And then we created quarterly turnover measures for each individual SNF. And when you're calculating workforce turnover, typically it's just, the number of staff who left the facility in the numerator, and then the number of total staff in the denominator. And so we use the CMS measure of what left the facility meant, which is that employee had a 60-day consecutive gap in employment. But then the number of total staff denominator gets a little tricky. For nursing turnover, CMS uses the number of total nursing staff in, an individual category who worked at least 120 hours in the previous quarter. Um, we've done other work on therapy staffing in SNFs and found that, SNFs employ a lot of contract therapy staff who work a lot less than that 120 hours per quarter. So we sort of wanted to create a different denominator that was more specific to how the therapy staff workforce actually, runs in SNFs. So these are just some plots over time of quarterly hours worked for the different job codes. So occupational therapy in orange, and then physical therapy. So the therapists here, the therapy assistants up here, and then the speech language pathologists. And you can see the median hours worked per employee did sort of decline during the pandemic, but especially for speech language pathologists, they were not working, a large amount of time. So we decided to use a denominator of 30 hours worked per quarter for that total staff, just so that in effect, we estimated a more conservative measure then of turnover because we had a larger denominator of therapy staff. So once we kind of decided who would be included in our measures, we actually calculated 6 different turnover measures. First, of all the therapy staff combined, and that's the one that I'll kind of use as we talk about our analyses, just in case you want to know the sensitivity analyses for all the different other staff, where I can send those along, but it gets to be a lot. So we'll kind of stick to that for most of the results. But we also looked at physical therapy as a discipline, so PTs and PTAs together, occupational therapy, OTs and OTAs together. Speech language pathologists don't have assistants in SNFs. Medicare doesn't pay for SLP services from assistants, so it's just the therapist there. And then we looked at assistants together and therapists together for PT and OT. And so we calculated turnover rates for each facility for each quarter of our study for all these different measures. So this just shows the average turnover, the percent of the staff that turned over across the different job codes over time. And the average quarterly turnover rate for all therapy staff combined was about 13% across the study period. It was slightly higher for SLPs and for assistants compared to therapists. And then we saw sort of a consistent seasonal pattern where turnover rates were lowest in Q2 of each calendar year and highest in Q4. Oops. So now to talk about where turnover was the most problematic. So we looked at association of turnover with facility characteristics. And again, because turnover is a percent, we wanted to create sort of a meaningful measure of high turnover. So looking at the distribution, this is the percent of all therapy staff that turned over in all of the SNF quarters, which was our unit of analysis. And because it was sort of this long tail and a little high bump here, we just decided to create a dichotomous indicator for having high turnover based on whether the SNF was in the top quartile for turnover rates amongst all SNFs in any given quarter. So that was kind of our outcome for this. And then we just did an exploratory analysis to see which facility characteristics were associated with having high turnover. Those characteristics are available on a variety of different public data sets from CMS. So we looked at patient census, overall staffing, not just turnover, but how well staffed the facilities were, ownership, size, change status, geography. We were able to merge in some COVID data on the rates of resident cases and staff cases in the facilities, since this was certainly during the pandemic time period. and then recent ownership changes. And we were able to match those indicators to the unique year and quarter of the turnover measure, and then just ran some mixed effects models and included those fixed effects for each, unique year and quarter combination and random intercepts for repeated measures by SNF. So these are average marginal effect estimates for the associations between each SNF characteristic and the probability of having high turnover, and this is for all the therapy staff combined. So first, for factors that were associated with lower probabilities of having high therapy turnover, we found that SNFs with higher staffing of both nurses and therapy staff overall had lower therapy staff turnover, kind of adjusted for all the other characteristics. Also, compared to for-profit SNFs, not-for-profit SNFs had 3.3% lower probability, and government SNFs had a 4.8% lower probability of having high therapy staff turnover. And then we also saw that SNFs with higher COVID case rates amongst staffs actually had lower probability of having high therapy turnover. And then conversely, SNFs that were more likely to have high turnover were larger facilities with higher census, SNFs with higher resident COVID cases, and then urban SNFs had 2.8% higher probability of having high therapy staff turnover compared to rural SNFs. Chain SNFs versus non-chain facilities had higher turnover. And then the largest effect we saw was actually SNFs that changed ownership in the year prior to the quarter when we measured turnover had 5.6% higher probability of having high therapy staff turnover. Okay. Now looking at outcomes. So we'll come back to kind of all interpretation at the end. So we wanted to look at patient outcomes that were relevant to therapy services. And there are kind of a lot of different outcomes available for SNFs through CMS at the facility level. There's the 5-star ratings that are a pretty blunt instrument, but the reason we didn't do those or use those, even though they're used in a lot of studies, is you can't match them by time. So a 5-star rating may be reported at a certain time, but they don't tell you when it was collected. But for individual measures that sort of are rolled up into those 5-star ratings, you can find the quarter that they were collected. So we really wanted the outcome to be, the resident or patient outcome to be matched to the quarter that we were measuring the turnover. So we were able to do that. And we also got to choose sort of measures that were more relevant to therapy. We're not necessarily thinking that therapy turnover will impact flu shot provision or things like that. So we chose these 4 measures here. And the other benefit is that they're already risk adjusted for patient clinical case mix and severity at the facility level. So we didn't have to add any additional sort of patient level characteristics. So we chose the percent of the percent of long-term care residents whose need for help with activities of daily living increased. So that's sort of an adverse outcome. The first 3 are adverse outcomes. You want lower percentages. So percent of long-term care residents with more ADL help, the percent of long-term care residents that had an injurious fall, and then the percent of long-term care residents whose ability to move independently worsened. So again, those are adverse outcomes. And then a positive outcome is the percent of short stay patients who improved in function. So for this analysis, again, we ran separate models for each outcome, and then that dichotomous indicator of high turnover was now our independent variable, but we still used a facility quarter analysis. And in these models, we added a fixed effect for SNF and time, and then we did also add some time varying covariates at the SNF level, so staffing, census, COVID cases, such that the estimates reflect the differences in the outcomes comparing periods of high therapy turnover versus low to moderate therapy turnover within each individual SNF. We ran tons of series of sensitivity analyses, again, using all the different turnover outcome or turnover measures for the different disciplines. We also removed some early pandemic time, and We also looked at just SNFs that employed only in-house staff. So there's sort of this bimodal distribution where SNFs either employ all in-house staff or they use in a contract company and employ all contract staff and a little bit in between, but it's pretty much one or the other. And the idea with kind of splitting them or stratifying them in this way was that we thought that SNFs that only employ in-house staff might have more stability in general, so they may have turnover may have a higher impact in those SNFs because they're less used to contract staff coming and going. So just looking at the outcomes in all of the facility quarters, we had about 15% of long-term care residents who needed increased help with their ADLs, only about 3.4% of residents with injurious falls, about 18% of residents' ability to move independently worsened, and then, of course, much higher percent of short stay residents whose function improved, which is good because that's what they're there for if they're a short stay resident. And then we just broke it down into high and lower turnover quarters. And you can see there's not a huge spread just descriptively. But in general, high turnover quarters had higher percent of long-term care residents whose need for help with ADLs increased, very similar falls, and again, slightly higher for ability to move worsened and similar for short stay residents. So that's a preview of maybe some insignificant results in our models. These or this plot is the difference in probability of each outcome associated with a high turnover quarter in a given SNF. So you can see there was no statistically significant association with differences in those risk-adjusted percentages of long-term care residents with falls or for short stay patients whose function improved. But within SNFs, having high combined therapy turnover in a given quarter was associated with a small but significant 0.3 percentage point increase in the percent of long-term care residents who needed more help with their ADLs. And it was also associated with a 0.2 percentage point increase in the percent of long-term care residents whose ability to move independently worsened. So there's a lot of double negatives there, but both adverse outcomes associated with higher turnover. And the results really were pretty similar across our sensitivity analyses, when we took out the early COVID period. The one thing that did become significant was when we looked at SNFs that only employed in-house staff. This relationship here became significant and also sort of in the negative direction. So there were for high turnover was associated with fewer patients whose short stay patients whose function improved. All right, so a couple discussion points. So I'm going to kind of break it down by sort of the descriptive and then the exploratory analyses. So if we're just looking at turnover rates, again, we found this sort of higher turnover annually in Q4. And that may really, we think it might be due to increasing competition from other higher paying health settings. So hospitals tend to pull staff away from nursing homes, and they may have higher seasonal staffing needs in those winter months. It's a possibility. We did think, even though our turnover measures were quarterly and many nursing measures are annually, in general, our maximum quarterly turnover rate was lower than what the literature is publishing about nursing. And that could be due to a few things. So there is higher pay and education requirements for most therapy staff. Even assistants have to get an associate's or bachelor's degree. And that's a lot more, and so then they have a little higher pay, and especially compared to CNAs who make up the majority of the SNF workforce, they just may be getting, paid better and have higher sort of barrier to entry the profession, so might be less likely to leave. And there also might be fewer jobs available outside of SNFs for therapy staff compared to nursing staff, particularly for CNAs who in other work we found tend to leave nursing homes for non-healthcare jobs. In terms of the facility characteristics associated with higher turnover, our findings of higher therapy turnover in SNFs that had lower overall nursing and therapy staffing levels, that's been pretty consistent with the literature for nursing. So, it's thought that lower staffing overall leads to increased employee frustration and work burden, and that's sort of the mechanism for higher turnover. We also the result about higher turnover in SNFs that had recent ownership changes, that's something we haven't seen really before, but we're thinking it might be related to sort of operational changes and differences in strategies after a SNF is sold. In particular, SNFs may change from a contract therapy company to in-house, or there may just be pretty significant kind of operational strategies. But we've also done other work that showed that after changes in ownership, staffing levels tend to decrease and census tends to increase. And so there just may be sort of more pressures on the staff that to leave during those times. And then finally, the higher therapy turnover in for-profit SNFs and in urban areas is also quite consistent with the literature on nursing staff turnover. And there is more competition for jobs in urban areas compared to rural facilities, and so that kind of makes sense that therapists may have additional options outside of the SNF. And then the for-profit result, about 70% of SNFs are for-profit. And that can be sort of a driver of a lot of operational challenges with productivity and things that therapists may not prefer. Okay, finally, the outcomes. Again, as I mentioned, the lack of a relationship between the falls outcome and the short stay function outcome may be due to both, there were very low fall rates, luckily, across all the SNFs, and very minimal variation in the short stay function outcome relative to some more variation in the long-term care outcomes. But it's also possible that short stay patients in general, they may experience less of an impact on care continuity because they are in the facility for a pretty short period of time, on average about 3 weeks, versus long-term care residents who live there. So turnover just may be less impactful for the short stay population. The associations we did see between high turnover of therapy staff and worse outcomes in terms of needing more assistance with ADLs, ability to move independently worsened. Those were, again, consistent across all of our analyses, but the effect sizes were pretty small. So the relative difference was less than 2% compared to averages. So really, it's how operationally significant that may be. There's about 1 million long-term care residents across the U.S. So 2% is still a fairly large chunk of folks who are experiencing worse outcomes with higher therapy turnover. So again, lots of, these are pretty exploratory analyses, a fair amount of lots of limitations, obviously not causal relationships. They're in the public data. There's just missingness can be challenging, and there tends to be more information missing for smaller and rural SNFs. So we always have that caveat that it may limit the generalizability to some of the smaller facilities who don't have their data reported in public files. And then there's, of course, a lot of other factors, especially for our analysis on SNF characteristics, that don't capture everything that goes into a workforce turnover problems. We chose, a set that had high levels of completeness, but we couldn't include things like payer and case mix that may also be important predictors of therapy staff turnover. But a couple things to conclude here. So therapy staff turnover results were pretty consistent with nursing literature in terms of where turnover was higher, and some associations with worse resident outcomes. So we saw, again, therapy staff turnover was higher in urban SNFs, for-profit SNFs, and larger SNFs with recent ownership changes. And then within individual SNFs, periods of high turnover of all therapy staff combined were associated with small increases in negative outcomes for long-term care residents. So really, targeting specific SNFs in efforts to reduce, nursing turnover could be good to add therapy turnover efforts to those, and that might be an efficient strategy with some potential for modest improvements in patient outcomes. Yeah, those are my slides. If anyone has questions, I'd love to have a chat.
Well, thank you, Rachel. Yeah, like I said, there is a lot of different ways you can cut that information. You tended to like group things by profession, right? Physical therapy,
Hmm.
OT, etc. Did you take a peek at all of if you group things by, well, education level, like put the PTs and OTs
Hmm.
together versus the assistants?
We did, and I can remind myself the results were pretty consistent. Therapists, assistants had a little higher turnover, and we've seen that the assistants, and that kind of makes sense in terms of,
Hmm.
potentially lower pay, and more and higher pay in other institutions or other work kind of sectors of the workforce. Assistants are employed at higher rates in SNFs than in other settings. So there are more therapy assistants in SNFs than in, hospitals proportionally, for example. So this is a pretty large setting for assistants, but they did have higher turnover rates slightly overall. But the relationships with resident outcomes were pretty consistent across all the therapy staff. We did see a little bit of differences when we actually broke it down by discipline, which I think is a good thing. Because us therapists, we don't like to be all grouped together. We do different things. So physical therapy turnover had stronger associations with some of those function and mobility focused outcomes than occupational therapy, for example, which has kind of lends some kind of validity to the findings. That's what we would sort of hope for.
That it would fit the profession.
Right.
Okay, once more in the audience, feel free to put questions in the Q&A panel. And I had another question off of that, which just exited my mind. I apologize. So let me go to that, and I'll get back to it. I'll get back to it. But let me kind of go to the next question on the list per
Mhm.
se. You talked about this a little, but could you maybe elaborate? Can you talk a little bit more about the differences and how therapy workforce might interact with like long-term stay patients versus short-term acute
Mhm.
patients?
Yeah, so the short stay patients, there's a couple million SNF stays for short stay patients across the US every year. And we just have sort of numbers for Medicare fee for service, and that's like 1.3 million. So it's a large sort of number of folks that experience a rehab stay or a short-term post-acute stay in a SNF. And they're, by definition, are often admitted for rehab. So they are there to get therapy services. And depending on, the diagnosis and, there's all these sort of criteria that go into how the SNF is reimbursed. But in general, on average, patients are getting, an hour or so of therapy a day, mostly physical and occupational therapy and a little bit of speech, depending on their needs. Um, so that is, a central aspect of the reason they're in the facility to begin with. It is it's infrequent, growing in frequency, but infrequent that patients don't get any therapy during their skilled nursing stay. And again, those stays and that therapy is covered under Part A, so the inpatient Medicare benefit. A Part B or a long stay resident, they live in that facility. They have, their nurses and their CNAs that they're used to caring for them and providing that sort of custodial care. But they will only get a therapy visit if someone identifies a need for therapy. And so that could be, the nurse says, oh, Mrs. Jones needs their wheelchair adjusted, or this person had the transfers are getting harder and they're in more pain, or they're having more falls. And so they'll get a referral to the physical therapy department in the facility, which is staffed by the same folks, but they're really there to serve the short stay population. That's sort of so we actually don't have a good understanding of the frequency of therapy delivered to long stay residents because the payer source is different. It's a Part B service. So, because most residents are under Medicare. So they would it would be billed differently, and that then the data are kind of in a different place to find it. And those sort of measures aren't collected. CMS doesn't, collect the average number of long stay residents who receive therapy services and report it in any of these public data sets.
Yeah, because that's interesting. I guess if you're a long-term stay, you almost need some self-advocacy there or family advocacy to help you out get some extra sessions.
Yeah. Yeah, potentially. Or a nurse or a physician that,
Yeah,
sees you from time to time. So.
yeah. By all means, by all means. Hopefully they notice it too.
Mhm.
Uh, Okay, we have a question from the audience. Sage Shari is curious about workforce culture issues in skilled nursing facilities and how they
Mhm.
might differ from other kinds of healthcare settings and between different types of SNFs, either from your research or
Mhm.
anything you've read about in the literature.
Sure. Well, culture is a broad topic. So you could talk about anything from, leadership styles to, um, patient interaction. So culture, I think workplace culture is something that, it really depends on the question that you're asking. In SNFs, there's been literature on how different leadership styles impact turnover of nurses. And so that's been something that has been examined. There's aspects of culture that include, training opportunities and opportunities for advancement that are helpful for reducing turnover. Um, there isn't necessarily anything empirical about therapy and how their culture of therapy workforce impacts, our turnover or the care provided. One of the unique aspects of therapy provision in SNFs that nurses tend not to experience is productivity requirements. And so that is sort of a cultural piece that has been looked at in hospital settings, but is also very prevalent in nursing home settings where the billing requirements and the sort of how a productive workforce is held accountable. And those sorts of productivity requirements in other settings have been shown to be sort of negative for satisfaction and turnover. But we haven't looked at that specifically in SNFs, except for sort of, anecdotal evidence on challenges managing those.
And we have a comment, and I believe there's a question in there too. Um, I found it interesting that outcomes for short stay patients didn't really change as high turnover makes me think of lower staffing and less therapists
Right.
delivering less therapy. I'm
Mhm.
trying to understand the relationships between therapist turnover and therapist staffing
Right.
levels. Does turnover mean that one therapist has
Mhm.
left and another has come in?
No, great question. So we adjusted for therapy staffing levels. So these measures isolate just turnover. So it is saying holding the overall staffing level constant at that same level of staffing. If one of those therapists left, whether or not a new one came, to replace them, that turnover itself, that churn and that lack of consistency is on its own predictive of, changes in long-term care resident outcomes, but not that short-term resident outcome. So I don't know if that's helpful. It's adjusting for overall therapy staffing, and that was intentional to really make sure we were pulling out turnover as sort of a unique domain that would uniquely impact these outcomes because of that missing continuity piece. It's like a different staff person, even if it's the same number of staff people, if that makes sense. And
Yeah, yeah,
and that's, yeah, I think that's part of the reason why the number, the relationships were small, right? Because we did account for staffing levels. You see a lot different relationships and larger relationships if you look at just less staffing and less therapy provided overall. They have a lot more of a direct relationship to resident outcomes, especially for the short stay populations. And I'm happy to share some other recent publications that more specifically look at therapy provision and patient outcomes in that population.
yeah, because you're really trying to isolate the impact of turnover or that lack of continuity.
Mhm.
And with that in mind, why do you think turnover is of particular importance to SNFs compared to
Mhm.
other settings?
Yeah, so I mentioned this a little bit, but I think the patient population is uniquely complicated, but also there's a very, very high rate of dementia and severity of dementia amongst especially the long-term care population. Something like, depending on the SNF, 60 to 80% of long-term care residents have dementia. And there are a lot of behavioral challenges. There are a lot of sort of this need for familiarity with a staff person. So whether it's, just patient comfort and understanding or sharing of strategies to manage some challenges and clinical and behavioral challenges with residents, and safety strategies, I think is especially important in the long stay population that and that kind of continuity for residents with dementia has been, studied in the nursing population a lot for that reason. But therapy too, you still have to, especially a therapist who is requiring something of a patient that's a very active participatory activity, that sort of continuity and familiarity and rapport is really important.
Okay, thank you. Well, what efforts have SNFs taken to reduce nursing staff turnover, and do you think these efforts can or should be extended to therapy staff?
Yeah, so I think there's kind of a lot of different categories of efforts, and some SNFs do different things. In general, I mentioned leadership and management styles is having more of a collaborative and flexible kind of job schedule has been really helpful for some SNFs with nursing turnover. If you think about, therapists have the same problems with getting sick and needing to switch shifts and wanting more flexible schedules. Um, Higher pay is associated with lower turnover of nursing staff. So addressing compensation, and that I think in our results speaks to this sort of competition aspect. When we did see, urban areas have higher turnover, that's probably due to more competition, and hospitals are the traditional place where uh, staff leave and go to because they have higher pay. And then again, I mentioned productivity. It's unique, I think, to therapists in the nursing home setting, and that hasn't been studied necessarily in nursing homes as much as other settings. But I think that would be um, kind of either reducing the pressure of productivity requirements or recognizing non-billable time in a therapist's productivity measure. So especially for long-term care residents, you think about, one therapist in a building of 100 staff may not be able to do much, and they may not want to be billing just that one-on-one care. They may want to be consulting and advising the nursing staff on, safe lifting strategies or just doing other sort of roles within the team that can be really helpful for residents and outcomes and not related to sort of a billable unit of time. So that's kind of my soapbox about productivity, as I don't think it measures the value of therapy, especially in sort of an institutional setting.
Okay, and we have another comment slash question. I know you can't answer this based on data, but just based on your and colleagues' experiences, do you think the small effects for turnover are really because there's so little continuity of care to begin with for therapy because of the high rates of contract staff these days
Yes.
and who don't work a lot of hours?
Yes, I do. And that is sort of,
Yes, that's it. Move on.
yes, I agree. And I think we tried to sort of get at that with one of our sensitivity analyses, where we did see a higher kind of a larger impact of turnover um, once we looked at just facilities who aren't employing contract staff regularly. So yes, I do think, contract especially for speech language pathologists, they're often split between 2 or 3 buildings. They don't have a large caseload in each individual SNF. There's not a lot of continuity. I was a therapy contract staffer for many years, and I would go to, 12 different buildings in the Seattle area on a weekend here and a weekend there. So I think that is part of it. It's just sort of the nature of the job. And that's not necessarily a positive thing. I think in general is to have, I think a lot of facilities would prefer to have more more continuous staff, and just and that then those contracts can make things challenging. But the contract staff company, just because this isn't kind of an interesting aside, but just because a facility employs 100% contract staff, that might just mean that they have a different company running their therapy department. So they could be staffing actually the same employees over time. So it's hard to sort of tease that out, but because you could have, a great therapy contract company who has better or less attrition of their staff in your building, and less turnover in general, but just because, yeah, they're a different company. If that makes sense. So, but yeah, I do think that is a big part of just the workforce in the therapy workforce in skilled nursing is a much higher proportion of contractors than nursing.
Okay, thank you. And once more, if you have a question, use the Q&A panel on your screen. One thing that, and I hadn't thought about this in a while, I don't, study long-term care, et
Mm.
cetera, like you do. Can you talk a little bit about the lasting impact of COVID-19 on these
Mhm.
settings?
Oh my gosh, there's so much literature and
I know it's been
um,
impacted more than like other settings. So,
right,
yeah.
right. The stat that I see a lot of is, that's specific to workforce is that every other healthcare setting has sort of rebounded and
Mhm.
recovered in terms of their kind of just workforce levels or number of staff. And that is not the case for nursing homes. So we're still struggling, I think, with staffing overall. There has been some interesting policy in the long-term care world specific to staffing recently. And I think last week there was another New York Times article that kind of highlighted some of the regulations around staffing that they tried to implement under the Biden administration, and those have now been rescinded. So there really is not like the bar for staffing in long-term care is really quite low. And there is no minimum amount of even nurses per staff. Besides having, one nurse on site a certain number of hours, that's, for the building. So they don't have like a number per patient day that you have to have, although they tried for a while and got a lot of industry pushback on that. But it's a challenging place to work too. And I think that's why we see high turnover in nursing homes compared to hospitals. Not only is the pay lower, but this low staffing turnover is a kind of a vicious cycle. And there's been more work about sort of the moral injury of trying to work in really, really low staffed environments and how, people are burning out at higher rates, especially after a lot of folks got through the COVID pandemic and stayed and made it through just to get hit with this, further insult of feeling like they've been left behind and there's still insufficient staff to care for residents.
Okay, thank you. Well,
Mhm.
I don't see any other questions coming in, so maybe we wrap up with a final question unless we see something else. And I kind of ask this to people sometimes, like for those in the audience, if they have one thing to take away from this presentation, what would it be? I mean, there's a lot of information, but what's that one kernel?
Here's my those soapbox again. I think therapy staff are really essential in nursing homes. Even though we're a small but mighty workforce, I do think that more efforts to maintain consistent therapy staff, higher levels of therapy staffing, and more consistent therapy staffing will pay dividends. And we're starting to see that in other studies that we're publishing as well. But really, support for the therapy workforce in nursing homes is going to be only beneficial, I think, for patients and residents.
Okay, well, thank you, Rachel. That was a
Thank
very good
you.
presentation. I really appreciate it. And I guess we'll wrap up a tad early today.
Thanks so much, David. Thanks,
And thank
everybody.
you. Yeah, bye-bye. And thank you in the audience. Bye-bye.